Good morning, good afternoon, good evening, wherever you are, and welcome to this webinar session with TechNet. TechNet 21 is happy to welcome our colleagues from VillageReach to discuss leveraging CHWs to vaccinate, a review of the global landscape and lessons from Malawi. If you have any question during this presentation, please use the Q&A box. It's available at the bottom of the Zoom window. You can ask your questions at any time. Our panelists will answer them after the presentation during the Q&A session. There's also a chat box where you can already introduce yourselves if you want to and tell us where you're from. And we would be happy to know who is present in this session. If you have any technical support with sound or anything, please let me know in the chat box too. I'll be here to help you as much as I can. Finally, this session is recorded and we'll share with you the links to the video as well as the slides. I hope you will enjoy this session and I'll give the floor to Rebecca Alban. Rebecca, the floor is yours.
Thank you, Alex, for the introduction. We are really delighted to be here. Thanks again for having us, and thanks to TechNet for convening us as a community. We are really excited to be presenting on this topic today about leveraging community health workers to vaccinate, not just because it's a topic that's very interesting and there's lots to learn, but because it's actually an innovative service delivery model that, if employed in the right way, can help us all to meet our immunization goals and to achieve UHC. I work for an organization called VillageReach, and we do a lot of work on improving vaccination coverage, vaccination equity, and are always looking for innovative ways to reach the underreached. So this is a topic that's very near and dear to us, and it's really a natural extension of the work that we've been doing for the last 20 years to bring health products and services closer to people at the last mile. So let me get us started by introducing today's speakers. I'll start with myself. I am a senior manager on the health systems team. My name is Rebecca Alban. I lead our human resources for health and community health worker portfolios, and have spent the last year more or less digging into this topic of community health workers as vaccinators, both from a research perspective and also looking at how we can support the implementation side of things. My colleague Tafri Chihana is a manager of monitoring and evaluation and leads for the VillageReach Malawi office and leads our research, evidence, and learning portfolio there. And Tafri played a key role in the research design and implementation of the study that we did in Malawi around their community health workers vaccinating, which is she's going to speak to us about today. And last but not least, we are very honored to have a community health worker speaker on our panel today, Chifuniro Chiyendausiku, who is a health surveillance assistant from Malawi, has joined us today, and she will be sharing her firsthand perspective on what it's really like to be a community health worker that provides vaccination services in the community. And her title, Health Surveillance Assistant, is what government-supported community health workers in Malawi are called. So that acronym, HSA, is something that you'll be hearing a lot today. So just wanted to clarify that. Moving on to our agenda, we've divided the agenda for today into 3 different sections. In the first, I'll provide a bit of context behind why leveraging community health workers is a topic of interest and some of the problems that it can help us to address. And then in the second piece, we'll share what we know so far, the evidence that we've gathered as VillageReach. We've conducted research both at the global as well as the country level in Malawi to start building evidence in this space. So I'll share what we learned from our rapid review of the global landscape, and then Tafri will share some of our key learnings from Malawi. And then in the last piece of the webinar, we'll shift gears a little bit and hear reflections from Chifuniro on what it's really like on the ground to be a community health worker providing immunization in her community. So she'll reflect on some of her experience and perspectives and highlight some of the operational challenges that she finds in her work, and also discuss some of the benefits to this approach. And then we've also reserved some time for Q&A, as Alex mentioned, so do use the chat box throughout as questions come up in your minds, and we will do our best to address some of them at the end of the webinar. And if we can't get to them all, we can respond in the follow-up email as well. So I'll start with the problem. Many of you on this call, I'm sure, are well aware that routine immunization has been stagnating over the past 10 years. And in response to the pandemic, that decreased even further. Most countries we work in are also facing severe health worker shortages. So the situation we find ourselves in is, unfortunately, we have more children than ever in need of vaccines and not enough health workers to actually deliver those. So, and we also have many populations who lack trust in their health system and are therefore hesitant to vaccinate. So given these health worker shortages, stagnating immunization rates globally, new strategies are needed to increase vaccination coverage and equity. So this is really a call, or even a rallying cry to get us to really start thinking outside of the box on how to reach zero-dose kids. We know this is a priority for Gavi, a priority for the Immunization Agenda 2030. And many of us here on this call, I would imagine, are on teams or part of organizations that are looking for innovative ways to reach more people, to reach zero-dose kids. And so what we're suggesting in this webinar is that we look at using community health workers as vaccinators as one of these innovative approaches to consider. So on this slide, I wanted to address why we think community health workers are well suited to play a role in administering immunization. And the first is that by definition, community health workers live in and are trusted by the communities that they serve. And having a trusted relationship with communities is really invaluable when it comes to generating demand for vaccines. I think one of the things that many of us learned or had reiterated throughout COVID was that the decision to vaccinate is really a very personal one. And having that trusting relationship is really key in ensuring uptake of services. Community health workers also are already engaged in many cases in health promotion and health education around immunization. So they're already in many cases involved on the ground, doing outreach in communities, educating people about vaccines, part of vaccination teams, but just aren't the ones that are sticking the needles. So they already have a lot of involvement in this space on the ground. In terms of whether community health workers are able to inject vaccines, that question has been answered both in the research, but also in the fact that community health workers are already doing this in 20 countries on the ground in the world. So we know that it's possible. We know that it can be done safely because it's happening, but also because research has shown that this injections can be done by community health workers safely. And also in many countries, community health workers already administer injectable contraception. So these are some of the reasons why community health workers are well suited to take on this role. But in the last block at the bottom in red, I did want to highlight some of the key barriers as well. One of which is that in many countries, it's actually not legal for community health workers to vaccinate. There are policies in place to actually prevent this. Another key barrier is the lack of evidence and global guidance on this topic. We don't have a lot of documented research or compiled best practices yet that can guide us as implementers, that can guide governments on how to successfully deploy community health workers to vaccinate. And because of this lack of research, that's why our team at VillageReach decided to conduct a rapid review of the global landscape to figure out what's been happening in the past couple of decades, where community health workers are actually vaccinating in the world. On our publication, Community Health Workers as Vaccinators, a rapid review of the global landscape, was recently published in Global Health Science and Practice. So we hope that you will check it out when you have time. And in that rapid review, we learned that community health workers administer vaccines in 20 countries. And these countries are highlighted on the map. As you can see, they span across several continents. And across these countries, community health workers are deployed to vaccinate at varying levels. Some do so for only for specific vaccines or specific subsets of vaccines. Others do it at a smaller geographic scale. Very few of these countries actually vaccinate across all vaccines at a national scale in the same way that Malawi does. And that's the reason we think Malawi is a really interesting case study that we'll be discussing today. So in our content analysis for this rapid review, we started to see some recurring themes that appeared over and over again in the literature. So we used these categories that you see on the screen to organize our findings. The first was around program history. So we looked at how the community health worker program was founded and the legal framework for it. We looked at the community health worker role, specifically in immunization, in terms of the tasks that they do, how they were trained, the vaccine administration routes that they use, either oral or injection, whether the community health workers used compact pre-filled vaccination devices. And the other categories were gender, occupational conditions, and supply chain. So in the interest of time, I'll just dig into a couple of these to highlight some of the challenges that we saw globally across occupational conditions and supply chain. The first is probably not a big surprise, and that in terms of job satisfaction and workload, many community health workers feel overworked due to the number of tasks and workforce shortages, also having to work across different settings, like out in an outpost and in a clinical setting at a hospital or clinic, can be very tiring. In terms of remuneration, community health workers who vaccinate are mostly paid by the government, which is a good thing. Globally, most community health workers are not salaried, but we did find that most of the ones globally who vaccinate are on the government payroll. However, the challenge is that there are often delays in those payment disbursements. In terms of supervision, a pattern was finding irregular or inadequate supervision for these community health workers. And in terms of personal safety, some of community health workers felt that they were in an unsafe at work environment. And that was particularly true for women for various reasons, going out into the community either by themselves or fearful of reactions from communities about vaccination. So moving on to supply chain, in terms of vaccine storage and cold chain, we found that many community health workers have limited cold chain training and also insufficient equipment. One that was mentioned frequently was vaccine carriers, that community health workers are often not provided with those. In terms of transportation, community health workers often have to go and collect and transport their own vaccines if they're going to administer in the community, which can be long and arduous journeys that they do either by foot or on bicycles, canoes, public transport, and often are not reimbursed for those travel costs. So that was another trend. In terms of stock management, there were regular equipment and medical supply shortages cited in a lot of this literature. So unfortunately, there are stockouts of vaccines are an issue for community health workers. And in terms of wastage, community health workers that live in low population density areas found it very challenging to manage open vial wastage. So those are some of the key takeaways that we saw globally, primarily that community health workers who vaccinate often encounter supply chain issues and may face unfavorable occupational conditions. So this is the global landscape, and now I wanted to transition and zoom in on Malawi and learn how in Malawi they leverage community health workers to administer vaccines at the national level. So I will now hand the mic over to Tafri Rapo to talk us through our Malawi research.
Thank you so much, Rebecca, for the context and for the findings from the rapid review. I'll take us through the findings of a study that we conducted in Malawi between March and May last year on the role of CHWs as vaccinators. So the question is why Malawi? What is so special about Malawi community health workers? Malawi is one of the few countries in the world that uses the CHWs to vaccinate the population. It is the only place where the CHWs are systematically being used as a primary vaccinating cadre at the national scale. So we think that this offers a very unique opportunity to share how Malawi is implementing this approach and what other countries could learn from it. Former community health workers in Malawi have existed since the 1970s, when Malawi established what they called by then cholera assistants and also smallpox vaccinators when there was an outbreak of cholera and then an outbreak of smallpox. The ministry then later on changed the cadre to healthy surveillance assistants with a job description focusing more on prevention and promotion services than curative services. However, the ministry has relied heavily on the HSS and on task shifting as one way of addressing the human resource gaps and of promoting equity in access to the healthcare services. Of recent, of course, there's been a change in the name of the title from a health surveillance assistant to disease and control and health surveillance assistant, just to better reflect the evolving role of community health care workers in both disease surveillance response and in promoting overall well-being of people in their communities. But in this presentation, we're still sticking to HSAs, as we're still learning how to start calling them by the new name, which is the CHSAs. In Malawi, as we've already mentioned, the HSAs are trained and employed by the government, and to carry out the key community health care roles, which includes vaccination. One of the most maybe important key points that you have to keep in mind is that currently HSAs in Malawi are vaccinating, are carrying out or administering almost all of the vaccines, including COVID-19 vaccines. And they are the key workforce cadre working to ensure access to primary health care across Malawi, and they represent about 1/3 of the healthcare workforce. Next slide, please. Yeah, so we conducted a qualitative research in Malawi to thoroughly document how HSAs are being trained, how they are being supervised, how they are paid or motivated, and what policies are in place to support them and set them up for success. Our study had three main objectives. The first objective was to describe HSA programmatic and operational roles in routine immunization, including their responsibilities, their training, vaccine safety procedures, community engagement, vaccine administration, and then their supervision. The second objective was to document HSA roles in the vaccine supply chain at the community level and considering their facilitating factors and also the challenges. And finally, we also aimed to gather key stakeholder perceptions of HSA's roles as vaccinators and their experiences with the approach, including challenges and then recommendation for areas for improvement. Next slide. Yeah, so we, in terms of the methods, we employed key informal interviews across different layers of our government partners and healthcare workers. The key informal interview sample included staff from the Ministry of Health overseeing the community health section and the EBI program. We also included representatives from the EBI partners. We also sampled HSA supervisors, HSAs themselves, and also community members. For community members, we targeted mothers of under 5 children who were attending routine immunization sessions. These people were sampled from, especially the HSAs, the HS supervisors, and the mothers were sampled from 6 districts, 2 from each of the 3 administrative regions in Malawi. To ensure equality in the sample, we targeted 1 high-performing and 1 low-performing district in terms of the routine immunization coverage in each of the 3 administrative regions. Next slide. Yeah, so what did we learn from this study? So we learned that national CHW cadres can successfully be trained, supported, and supplied with EPI products to support routine immunization, but having the right supportive infrastructure in place is key to their success. So this is a viable approach that works in Malawi and could potentially work in other countries at a scale, but only if these HWs are provided with the right kind of support to set them up for success. We also learned that one key benefit of using HSAs is that HSAs provide wraparound immunization services and do not require the presence of nurses or other clinical cadres to support them. So by not requiring, other clinical cadres to accompany them when they're conducting vaccinations, this frees up nurses' time to do other things and help receive a more manageable workload for nurses and other clinical cadres. One theme that emerged strongly was trust. We observed that most respondents viewed HSAs as trusted vaccinators and service provider. We have a quote that came from one of the mothers who said that if another person goes there with the vaccine, people will not receive it. But if it is an HSA, they say our doctor has arrived. So this powerful quote demonstrates that HSAs have a status, HSAs are trusted, and they are looked up to in their communities. Next slide. Yeah, so what are the key programmatic elements that can and that do support HSAs vaccinating? So from our research, we found that both HSAs and supervisors saw regular supervision as critical for HSA success. In addition to supporting HSAs, in their day-to-day responsibilities, strong supervision provides HSAs with the training and quality control that is needed to provide effective vaccination services. We also found that adequate cold chain training and equipment is also key in ensuring the vaccine potency and safety, and also in guaranteeing that the efforts of HSAs are yielding the intended results in their communities. Most HSAs also thought that the standardized pre-service training, which is completed in 12 weeks, was adequate. Of course, it should be followed by trainings or refresher trainings organized whenever there is an introduction of new vaccines. However, of note is the fact that HSA training program keeps on evolving, is continually evolving, and is continually being reviewed and updated to ensure that it meets the changing health needs of the population. There are currently plans to expand the scope of the HSA training program to include additional modules on specialized topics like palliative care, mental health, and non-communicable diseases. We also noted that stockouts of routine vaccine supplies in the facilities were very rare. This is a testament to the robust systems and strategies that the government and its partners have put in place to prevent and manage stockouts effectively. Next slide. Yeah, so what are some of the gaps or some of the challenges that HSAs are facing that come in between them and vaccinating successfully. We noted that limited availability of data on preparation needs at the community level and the lack of the capabilities to be able to estimate demand is one of the challenges. So sometimes HSAs found themselves depending on emergency orders in order to fulfill the demand that they need during outreach sessions. One issue that also came out was the issue of immunization, which has already also been talked about in the previous slides. So HSAs really decried static salaries that regardless of the years of service or the number of tasks that are being added on their workload, or the number of trainings that they attained or they have passed, their salary most of the times remains the same. Most HSAs cited lack of incentives, job motivation, and unclear career paths. One issue also that came out was inadequate refresher training. We know that ongoing education and training can help HSAs stay up to date with the latest healthcare practices, treatments, and technologies. This is critical since HSAs, they are the primary source of healthy advice for most people in the rural and hard-to-reach communities. However, most HSAs felt that the refresher trainings are inadequate and they are inconsistent. Transportation was also one of the issues that was highlighted as a challenge in our study. HSAs, they're typically responsible for providing health services to communities in remote and hard-to-reach areas where transportation infrastructure is limited. HSAs, in most cases, they do not have access to reliable transportation like motor vehicles, motorcycles, or even push bikes. Sometimes in cases where they are push bikes, motorcycles at the facility, we find that they are faced with the challenge of lack of enough fuel to be able to reach their outreach sessions. This is also true for HSA supervisors who also like logistical support in order to be able to conduct routine supervisory visits to the HSAs. But we still note that despite these challenges, despite these challenges that we have just described, utilizing the HSAs as vaccinators has contributed significantly to improving immunization coverage and performance in the country. HSAs are trained to identify and track children who are due for immunization, and they also provide health education to mothers and caregivers on the importance of immunization, and they also refer children to healthy facilities for vaccinations. So this is, in summary, what came out of our study that we conducted last year. Thank you so much. I will hand over the platform to Rebecca to have our next session of the presentation. Thanks.
Thank you, Tafiropo. That was a really great summary, very comprehensive. What we're hoping with this next portion of the webinar is actually to bring some of those research results to life that Tafiropo just shared. So we've seen them on the slide, but in this next section, when we have a little interview with Chifuniro, who is a community health worker in Malawi, who vaccinates her community, we will be hearing her firsthand perspective on how these things feel, what it's really like, what types of reactions does she get from the community, challenges, and all the things that we went over in our research, but really to hear what it's like on the front lines from a community health worker. So we hope that this perspective is interesting and really hopes to bring these findings to life. So it's with great pleasure that I introduce Chifuniro. And Chifuniro, would you maybe start this section just by introducing yourself and a little bit about your role as an HSA?
Hello, everyone. My name is Chifuniro, and I'm a disease control surveillance assistant working under Wambipeza, which is a non-governmental organization in Doha district. Initially, I was trained as a primary school teacher, but I later on became a community health worker because of the passion I had for the health. So I was born on 28 July, and I got employed at Malawi-based as a disease control surveillance assistant in February 2022. After that, I underwent 4 weeks orientation with an exposure to on-the-job training. I'm currently serving at Mtiti catchment area, which is 7 kilometers away from the health center. And the total population of my catchment area is 768 with 195 households. And women of childbearing age, I have 176, and also under 5 children, I have 131. Thank you.
Thank you so much for that. It's great to learn about your scope of work. And now that we sort of know generally about your role as an HSA, maybe you can now share more specifically what some of the tasks you do related to immunization specifically. What does a regular day for you look like? What types of things that you do to support administering vaccines?
Okay, one of my core tasks is to provide routine immunization to all children from day 0 to 15 months, and also administer TD to women of childbearing age, which is from 15 years to 49 years, and also girls between 9 and 13 years. These vaccines are administered using 2 strategies, which are static and outreach clinic sessions. Sometimes I administer vaccines during national supplementary immunization activities. These vaccines are administered based on age, antigen type, interval, mode of administration, and technique, and also number of doses administered per contact and site of administration. So vaccine packaging and transporting, education of clients, and administration to concerned groups takes almost 6 to 7 hours, especially during outreach clinics. There are a number of vaccines that we administer to especially under 5 children, under 2 to be specific, which BCG, children are given BCG at birth, and also after some time they are given OPV, PCV, measles, rubella, and also they are given some other things like vitamin purposes. Thank you.
Thank you. That was a great overview. And I think one of the key things that I was hearing is what a large time commitment this is, and a significant amount of your tasks that you do are related to immunization, with you going back and forth from the clinic to doing outreach visits and all of the education that you do as well. My next question is what you like about administering vaccines. So what positives do you see about that part of your role, either in how it makes you feel or how it helps you relate to your community? Just wanted to hear your perspective on anything positive about this.
Okay, I like the administration access to clients because of its positive effects, like it reduces infant deaths from vaccine preventable diseases like diphtheria, tetanus, and also whooping cough. It also cements community trust in community health workers. The community, people from the community trust us so much to be the ones to administer the vaccines to them, because we are the ones who spend most of the time with the people. So we have created this bond between us and them that makes them trust us. And also provides an interaction platform where healthy information on hygiene, sanitation, and other related areas is disseminated. So when we are out at the outreach clinics, we don't just start by administering the vaccines. We start by educating the community members other healthy related things like about hygiene, how they can take care of their homes, and how they can take care of themselves according to health. So it helps in improving the healthy lives of the people in the community. And also it enables the children born to TT vaccinated pregnant mothers to be protected at birth from tetanus. We make sure that mothers are given TT vaccines so that the children will be protected from tetanus.
Great, thank you. That was a comprehensive answer. I heard a number of different important themes. One is trust, which keeps coming up over and over again throughout the webinar, just emphasizing how important that bond is with the community to improve vaccine service delivery, and I think service delivery generally of other services as well. And also hearing that administering vaccines in the community is also a way to be opportunistic and use that as a platform to do other things as well. So educate not just about immunization, but also about hygiene and other forms of self-care. So that's really interesting to hear how you do that. Next, I wanted to ask about some of the challenges that you face in administering vaccines, and that can be anything, either something that's personally difficult or something that you and all of your colleagues face with supplies, with workload. Any challenges that you want to highlight for the group today?
Okay, there are quite some challenges that we face when administering vaccines. The first one is misconceptions associated with vaccines. So other community members have misconceptions about these vaccines. So it's hard to convince them to get these vaccines, and also religious beliefs from other religions which do not allow us to give them the vaccines. Another challenge is on transport. Most CHWs travel long distance, compounded by rivers and mountains, and some travel on foot, and their push bikes most of the times are subjected to frequent breakdowns. So it's quite a challenge to be going to the communities and you don't have a nice mode of transport to be doing that. And also parental reluctance to bring their children to immunization points. So sometimes children don't bring their children to immunization points. Of course, we'll have to go to their households and convince them and follow up on what are the reasons they're not bringing the children, but then sometimes it's hard to convince them. And also hectic schedules during campaigns. For example, when we are administering vaccines during campaigns, there is only one community health worker administering the vaccines. So it's quite a challenge because there are quite a group of people to be given the vaccines, and it's only one CHW to do that. Unlike when you are at the clinic, because there are always 2 to 3 of us administering the vaccines. So yeah, it is not that hectic. And also on-time repayment of lunch allowances during campaigns sometimes take 2 months before CHWs receive it. So yeah, it's quite challenging because you have to be going out there and you don't have this lunch allowance to be supporting you when you're doing the work. So yeah.
Thank you. Yeah, that's quite a list of challenges, all very important to note and very also quite consistent with what we had found in the research as well. Just to highlight a few, transport being that there's transport to and from facilities, and also bringing transport of the vaccines. Push bikes are often not sufficient to get out where you and other community health workers need to go. People having to go on foot or by public transport it wastes a lot of time. So lack of reliable transport and fuel, a big problem. Another highlight was around misinformation for people in the communities. I know that was a particular issue that was around COVID. So recently in the last couple of years, there's been specific efforts to target misinformation and doing lots more education around COVID vaccines, particularly to target that. And then the challenges that you face around campaigns. There can be super busy, overwhelming in terms of schedules and workload and coordination with others on the ground. So those are some really important challenges. Thank you. The next question is around types of support. We've been talking today about how there's different types of support that are needed in order for community health workers to be successful. So what types of support do you receive now from the Ministry of Health that you feel is important for you to be successful as a vaccinator?
The support that we receive from the Ministry of Health is supervision, monthly and quarterly. They do make sure that they supervise us, so they motivate us and also helping us on where we need support, and orientation and trainings on immunization. So most, especially when we are doing campaigns, they make sure that they train us before going out to the communities to administer the vaccine. Salary and allowances, which is a great motivation to us as disease control surveillance assistants from Malawi. And also they make sure that they always supply us with vaccines and injection materials and other PPEs, including raincoats and gumboots. They also make sure that they provide us with uniforms for identification, so that when we go out to the communities, people will be able to identify us by our uniforms.
Great. Yeah, that's a long and an important list of things. I'll just name a few. With supervision, particular training around campaigns, consistent supply of both medicines, but also associated equipment like PPE boots and uniforms. So that's a great list. Thank you. And then my next question is the opposite question. What support do you not have currently that you wish that you had and could help you be more successful?
The support that we currently do not receive, but it's important to my service as a community health worker, is regular refresher meetings. We don't really get regular refresher meetings. So yeah, we would like to be getting regular refresher meetings so that we'll be able to refresh on some of our work. And also provision of motorbikes to speed up service delivery. So as I already said, that most of the times community health workers use maybe sometimes public transport, or they go to the communities by foot, or they use push bikes, which break down most of the time. So it's hard to reach some hard to reach areas with the push bikes and on foot. So it would be nice if community health workers are given motorbikes to speed up service delivery. And also provision of tablets, laptops to fellow CHWs for proper data collection and record keeping. So in Malawi, for other community health workers, we have been provided with tablets. Like from my organization, which is from VillageReach, we've been provided with tablets, which we use to collect data and keep our records. And some few districts, they have been given these tablets, but most of the healthy community health workers, they don't have these things. So it's hard to be keeping those things in hard copies because they may get lost sometimes. So yeah, provision of tablets and laptops would be really a great deal.
Thank you. Yeah, those are some great points. I think, and also some of those were consistent with our research as well, the need for more refresher meetings and trainings to keep knowledge fresh, improve transport. I think motorbikes is a great point that would help make service delivery more efficient, and also digital tools to also make data collection more efficient and hopefully more accurate as well. Thank you so much for that. And my last question is a broader one, recognizing that many people on the line are from countries that don't currently use community health workers to vaccinate. So just wanting to get your perspective on, or what advice you would give other countries who may be considering doing this. Do you have any words for others outside of Malawi who may think about leveraging community health workers to administer vaccines?
Yeah, so my call on other countries is that all countries globally should consider community health workers as forefront liners to be administering vaccines. because of the trust the community has in them. They are the ones who spend more time in the community, and they know every member by location and sometimes by name. And they conduct follow-ups and periodic data tracking. So please motivate them, trust them, let them be trained, salaried, supervised, and supplied. Thank you.
Thank you so much. That was very well said. I don't feel the need to summarize anything. That was very well stated, and I really appreciate your taking the time to speak with us today. I wanted to also give a shout out to the Community Health Worker Impact Coalition, who I don't know if you can see on the screen at the bottom, hosts a really great resources, which is called a CHW Speaker Bureau. And that's how we were able to secure Chief Waniro as a speaker today. Chief Waniro and a host of other community health workers have been trained to speak at public events and advocate for community health workers as a whole. And so this is a resource I wanted to share with the group in case others are interested in also elevating community health worker voices in future events. This is a great resource. So again, thank you so much to Chief Waniro for being here. She's had to travel a long way just to get internet access to be on this webinar today. So we are very grateful for that. And moving on toward the closing of this webinar, I just wanted to take a couple more slides to reflect and make a few recommendations before we move into questions. So as a main takeaway from this webinar, which we found in our research and then was just now re-emphasized by Chief Waniro, is that community health workers can be successfully trained, supported, and supplied to provide routine immunization. But the big asterisk is that they have to have the right supportive infrastructure in place to make that successful. So out of our research, we have a number of recommendations to make sure that, so that other countries can make sure that that support and infrastructure is there. So the recommendations are on the screen, and I'll just go through them quickly. The first is to budget for transport and supplies. You heard Chief Waniro mention transport over and over again, so that to prevent that issue, budget should include transport, fuel, maintenance for vehicles, cooler boxes, and other last mile vaccine transport supplies for community health workers. The next one is incredibly important, which is ensuring a reasonable workload for community health workers. So in this, I wanted to emphasize that this is not a task to be taken lightly. It's not a task that can just be tacked on to an existing scope of work for a community health worker. If incorporating vaccination is going to work within a community health worker's existing duties, it will require close planning, likely expanding the community health workforce to make sure that tasks are distributed effectively. Because as we heard from Chief Waniro, this is a time-intensive activity. The next is around coaching and mentoring. This should be done using dedicated supervisors. And that means someone whose job is specifically to supervise, not a nurse who has been assigned to supervise others. Because supervision was shown in our research and in our observations to be incredibly essential to ensure that vaccinations are being done safely and successfully. The next is to provide extensive introductory and routine training. So it's important to have a solid foundational training at the outset, but also to make sure that those trainings are topped up on a regular basis so that community health workers can keep their knowledge fresh and practice some of those key skills. And the last recommendations is providing community health workers with fair pay. The pay that a community health worker receives should align with their workloads and recognize the contributions that they're making to national routine immunization coverage and recognize the valuable skills that they have. So in this last slide, I wanted to just take a moment to reflect on everything that we've heard and now think about what's next. How can we build from this? how can we as members of the TechNet community get involved? So here's a couple of suggestions for future involvement. The first is around, we need more evidence and documentation of this approach. So we know that community health workers can safely vaccinate, but we need more evidence to answer some key questions around, for example, how cost effective is this? What implementation approaches work best? How might implementation of this affect the human resources for health in the country? For example, the need to hire more community health workers. How much time might this save for nurses and other health cadres? How safe is it for community health workers to vaccinate compared to other cadres? So there's a lot of questions still out there, and we are encouraging evidence generation both from research, but also from implementation experience that can be documented. Those will both be very important to achieve this goal. And then the next thing that we can work toward together is toward creating global guidance around community health workers vaccinating. If we want to see this widespread uptake of this approach, some type of global guidance is going to be needed to guide how countries implement. So it'd be great to have global consensus, for example, on what minimum training requirements are best, what best practices are there for community health workers to maintain vaccine safety. Global guidance could also be useful to help to guide countries on when this approach is recommended. This may be a good fit for some countries and maybe not a good fit for other countries. So this type of guidance could help clarify, in what situations using community health workers for vaccination is recommended. So in closing, I want us to just all think about, the role that we might be able to play in amplifying this approach, whether that's from a funding perspective, a research perspective, or even advocacy. To raise awareness that this is an area that's currently relatively unexplored and I think ripe for opportunity. Because if done right, this shows huge potential to transform how vaccines are delivered and how they reach the underreached. So we hope that you will join us on this journey, and we encourage you to reach out to us if you have questions or are interested in collaborating with us on this journey. Thank you very much for joining, and I think we can move on to the Q&A. Tapirapo, I don't know if you've been able to see any of the Q&A come up in the chat.
Yes, Rebecca. So we have about 4 questions. And the first question is, what is the average HSA to population ratio? I'll take that up. By 2021, the average HSA to population ratio was at 2,000. So 1 HSA to about 2,100 people in the population. But the target, the government target, the ministry's target is 1 to 1,000. So you can see the kind of the workload that HSAs are having at the moment. There's still a very huge room for improvement to employ additional HSAs so that we reach the targeted 1 to 1,000 ratio. And then there's a question which asks about the research in Malawi references routine immunization in the country, which particular routine immunizations and the frequency of the immunizations per year. So I'll leave that to our expert here, who has the right responses to that.
Okay, so there are various vaccines that we administer. As I said, that at birth, first contact, children are given BCG, and then it also at birth, they are given BCG and OPV 0. So at 6 weeks, they are given OPV 1, DPT 1, or Penta 1, PCV 1, and also Rota 1. So at 10 weeks, they are given OPV 2, DPT 2, PCV 2, and Rota 2. And then at 14 weeks, they are given OPV 3, DPT 3, and PCV 3. Then at 9 months, they are given measles rubella 1. And then at 15 months, they are given measles rubella 2. Yeah, so that's how it is.
Thanks so much, Chifunilo. This next question ask about any control areas or control sites for our study for comparability of data. Rebecca, should you take that up and I can add on that? So the question is, did the study consider any control areas for comparability of the data?
Jeffrey Repo, you're the many person, you probably answer it better, but the study was only done in different districts in Malawi, and so all the places that it was done were areas that offer vaccination by community health workers. So there wasn't an area that doesn't. There was no control, I think, by the traditional term. As Jeffrey Repo mentioned, we tried to find you select the districts in a way that had a balance between high coverage and low coverage and rural and urban. So we tried to balance it across, but there was no opportunity for control in Malawi because it's implemented nationally. I don't know if you have anything else to add.
Yeah, so I just wanted to add that because in this study we are just exploring the operational and programmatic roles of HSAs. It was not like we're not trying to explore any causal relationships. So we thought that having a control site would not really add any value. But yeah, we are open to do that for our next research questions that we may have. Yeah, thanks. And then we have the last question, which I think also goes to Chifunilo. Are all CHWs going to be given the vaccine kits, or will we be picking the vaccine from a health facility after finishing the exercise? We return the kits to the hospital, or we keep them in our custody? If it will be kept with us, our work will be easy. I think that is more like a comment or a question, but Chifunilo can still add to what's the current process like.
Okay, so far the vaccines are kept at the clinic hospital in the refrigerator. So when we are going out for outreach clinics, we go to the hospital, pick the vaccines using a vaccine carrier. And then after the session, we also bring the vaccines back to the hospital.
Yeah, so probably if you have any other views on whether, because I think the point is if the vaccines will be kept with us, our work will be easy. I don't know if other people have views on that, whether HSAs should be keeping vaccines with them at home, or the current process still works based. I would say it works based because at home maybe they don't have access to cold chain. Most they don't have electricity at home, so. For me, in my opinion, the current status dictates that the vaccines be kept at the facility.
Yeah, and there are also some degrees that we use to keep the vaccines. So you cannot just keep the vaccines anyhow you want. Yeah.
Yeah, I think those are the questions that we had. Unless we have other questions from the audience.
Thank you. I'm not hearing any other questions from the audience, so maybe we can wrap up right on time. I'll just say thank you again to everybody for joining, and a special thanks to our other two panelists for being great speakers and for taking the time to do the webinar. Thank you, and have a wonderful rest of your day.
Thank you. Thank you very much. That was an excellent presentation. As a reminder, we'll send the slide as well as the recording of this session by email to all participants. And yes, we will do a little bit of noise around this presentation to the TechNet community because it has a very high value. Thank you very much. Have a very nice day, and we hope to see you again soon for another TechNet webinar. Bye.
Thanks. Bye.